Good evening, everybody. I hope everybody is safe and well during this difficult time during COVID-19. Thank you for joining me today. I know some of you may have been with me for our part one of this webinar. I just want to make sure from everybody can see and hear me. Lisa, you able to see and hear me?
Yes, I am.
Okay, good. Just want to make sure. Okay, so don't worry if you didn't see part one of structure, motor, and muscle, the assessment part. We are going to go over that, so there's nothing to worry about there. This is a course by me, Robin Merkel-Walsh, and these are my disclosures. Financially, I'm a member of the Talk Tools Speaking Bureau, and I receive honorariums for lecturing and products that I've developed. I'm going to speak about some of my methods or Talk Tools methods, but also other methods other than my own or Talk Tools. Non-financially, I'm the board chair of the Oral Motor Institute. I'm the private practice co-chair of the New Jersey Speech and Hearing Association. I'm also a member of the International Association of Orofacial Myology, the American Academy of Private Practice in Speech Pathology and Audiology, the International Consortium of Anchoglossia Professionals, the New Jersey Education Association, and preferred provider of the Anchoglossia Body Workers. I'm also a volunteer CE coordinator of Marshallis Speech and Language. So why did I create this webinar? Well, I created the webinar in two parts, mainly because there's a lot of confusion in our field of speech pathology when we're dealing with really complex articulation disorders, especially in young children. And often differentiating, there seems to be an overgeneralization of diagnosing children with childhood apraxia of speech when there could be muscle or structural issues. So the goals of this course are for participants to list at least two techniques that are appropriate for speech sound disorders when the diagnosis is due to structure, able to list two techniques appropriate for speech sound disorders when it's related to motor execution, and two techniques when the speech sound disorder is related to muscle tone issues. So it's very important to understand that diagnosis drives methodology, okay? So if you went to the doctor and you had symptoms of, a stuffy nose, but you also had a lot of pain in your face and discolored secretions, maybe a little bit of a fever, and you also had some fluid in your ears, the doctor might say, this is a sinus infection. So sinus infections are bacterial, and I'm going to give you an antibiotic. If you go and you have body aches and a high fever and you're sneezing and coughing and you feel absolutely miserable and your throat's killing you, they're probably going to give you maybe a strep test, a flu test, and based on that diagnosis, if you have a virus and it's the flu, they're going to give you Xofluza or Tamiflu and tell you to rest and drink water. If your strep test comes back positive, you're going to get penicillin or azithromycin. You're going to get an antibiotic. So we know very clearly in medicine and pharmaceuticals that the proper diagnosis is what's going to drive what the plan of care is. And we have to remember that as speech pathologists as well, that we have to make the right diagnosis. And we talked about that in part one, and we'll review that. There's still controversy on oral sensory motor approaches, even though each year we get more and more research in terms of studies coming out of the IJOM journal through the International Association of Orofacial Myology, compendiums that we've created for the Oral Motor Institute, There's some new studies that just came up in looking at oral motor dysfunction and a high correlation between oral motor dysfunction and speech sound disorders. So there's still some negative connotation about oral sensory motor approaches, which may be more appropriate for certain diagnosis. We still need, and based on that controversy, we still are struggling and need to differentiate a non-speech oral motor exercise from an oral placement therapy technique, which we'll go over today. And we want to recognize that some techniques also can treat a variety of diagnoses. So we're going to take a look today. I'm basically going through this kind of as a comparison of what are we seeing on the ASHA website in terms of evidence-based and guidance for speech sound disorders versus what is clinical feedback and patient perspectives, what are clinicians saying that are working in their clinic, and also compiling information from different subject matter experts. For example, Nancy Kaufman is wonderful with childhood apraxia of speech. The Prompt Institute has been doing different levels of research for apraxia of speech. I looked at speech disorders and treatment in tongue tie this past year at the IAOM convention. So I'm really pulling all the different areas and levels of evidence base to see what clinicians are doing and where they're getting their evidence from. The other reason I made this webinar is very early in my career. One thing that stood out to me in my undergraduate program, not even my graduate program, when I learned about articulation, Van Riper said, use every tool possible. And in speech pathology, a tool could be a workbook that we're copying and getting words from. It could be a bite block. It could be our hands using tactile cues. It could be our face and how we're giving visual cues. So I really believe that speech sound disorders deserve a multimodal, multisensory, multi-tool approach. So I want to bring that together for the different types of speech sound disorders. So if you weren't at part one, let's do a review. And if you weren't there, and if you were there, this will help too, because we did that a couple months ago. So from the speech sound disorders practice portal through ASHA, they have divided speech sound disorders into functional disorders, which are more of your developmental speech sound disorders that we don't really know a cause for. So you have your articulation disorders that include maybe some motor aspects like delays in the motor, but mostly phonology. And these are the little kids that we often got in our clinical practicums when we were in graduate school, and they were doing fronting and gliding and stopping. And we learned that we were going to do auditory discrimination. Am I saying the sound correctly? Can you, point to think versus sync? Lending itself to a very traditional therapy model. But then ASHA points out that there are organic speech sound disorders that can be developmental or acquired. And in these organic disorders, we have our motor or neurological based speech sound disorders. And those are both disorders of execution, like dysarthria, where the muscle is involved, or planning, which is apraxia, where the muscle is intact, but the motor planning aspect of getting that message from the brain to the mouth that's actually working properly, that message can't get down there. And then ASHA has done a much better job over the past 2 years of really highlighting structurally based disorders. And this includes our cleft palate population, other orofacial or orofacial myofunctional anomalies such as tongue tie, lip tie, high vaulted palate, noxious oral habits, things that are going to impact craniofacial development, and that includes the palate, the soft tissue, the dentition, and even the growth of the face. And then we have structural deficits that could be to trauma or surgery. You could get in a car accident. You can have lingual cancer. So these structural speech sound disorders are not going to be, or hypothetically, they shouldn't be treated in the same way that a functional or a more phonological disorder is going to be treated. And we went over those sensory perceptual. So there can also be speech sound disorders if a person has hearing impairment, and that really impacts the sensory system. And we know from our Talk Tools instructor, Lori Overland, that you cannot separate sensory motor. They are a scaffolded system. They're an overlapping system. So if you can't hear, it may impact the way the mouth moves. And we even know now from studies in infants that if we restrict tongue movement, not only can that impede expressive language and articulation development, but they found that speech perception could also be impacted. And that's the Bruder study that's available on the Talk Tools website. So we're really going to be functioning on that organic. But what was a little confusing to me and really made me want to take this deeper dive in doing this webinar is that even though the ASHA evidence-based maps point to there are differences in individuals with childhood apraxia of speech, orofacial myofunctional disorders, dysarthria. So we're looking at motor execution, motor planning, and structure, which is our structure, muscle, motor course here. All the portals point back to the speech sound disorders portal, which really only talks about traditional methods of therapy, more so, not even talking about placement cues, but more in line with perceptual discrimination, working on the more or less look at me and say what I say treatment approach. So we're going to try to break this down from other areas of evidence besides ASHA to find out for motor, muscle, and structure, what exactly should we be doing? Because proper diagnosis will lead us to evidence-based practices for treatment. So when we went over the characteristics through assessment, this is what we found. In structural disorders, which can include TOTS, cleft palate, dental malocclusion, facial asymmetry, etc., we found that structural deficits lended themselves to very specific phoneme errors, especially with tethered oral tissue, tongue, lip, or buccal ties. There were very specific misarticulations of placement and also distortions. Distortions of S and Z are very common. Interdental lisps are very common with orofacial myofunctional disorders. Abnormal lingual dental articulatory placement for T, D, N, L, S, C, sh, ch, and j. So instead of the tongue being retracted with a back tongue side spread or retracted with tongue tip elevation, we're seeing a lot of forward protrusion of the tongue and the tongue tip being in between the teeth or pushing against the teeth. Lateral lisps, upper lip insufficiency from dental malocclusion that could lead to difficulty with placements of bilabials and labial dentals, patterns of hypernasality in this diagnosis, a lot of phonetic and oral placement issues, and a restrictive phonemic inventory and glottal stops, and that was very specific to the cleft palate population, okay? With muscle-based disorders or diagnosis of dysarthria, the evidence showed, both from ASHA and other sources, that Muscle-based disorders cause very imprecise consonants, distortion of vowels, irregular articulatory breakdown, some kind of that prosody or the stress on words. So a spondy word like baseball might become ball. So it'll sound very broken down, maybe choppy with the improper stress. There could be some blurring or kind of the sounds being slurred together, especially if you're having blends or a 3-word sentence. It could be very unintelligible. Also, resonance issues, both hyper and hypo, could be a factor. Voice issues, breaks in pitch, aphonia, vocal hoarseness, if there's global issues with muscle tone. The evidence shows that the errors are very consistent and predictable when you have muscle-based problems. Phonatory weakness, difficulty with using that clavicular breathing to support speech, and a lot of rate issues, either being really too slow and dragged out, or speaking really, really, really fast because you're trying to speak on that really short, breath of air. In comparison, when we talked about motor-based, and this included childhood apraxia of speech and acquired apraxia of speech, we found through the evidence that this is very erratic errors, slow rate of speech, dysfluencies. There's more and more evidence of the link between stuttering and childhood apraxia of speech, higher consonant errors than vowels, difficulty with co-articulation. Sounds could be fine in isolation, but then when they're blended together in a CV or a VC or a CBC context, even at that short blend level, there could be challenges. Voicing errors, like voicing all phonemes or devoicing all phonemes. Groping movements, that we know that's also common with dysfluency disorders, and that could be very common in motor-based challenges as well for motor planning. And syllable segregation, very choppy. I want popsicle. Give me ball. So really, really choppy speech and long pauses in between the words, or even within a word. If the word was elephant, the child or the adult might say fin, and really break down that word to be able to get it more clear. So we went in assessment in more detail, of course, but this was the summary at the end of that course as to what we found. So let's start with something that's very passionate to both me and my co-author, Lori Overland, and several of my colleagues through Talk Tools, as many of us have over the past 2 years followed the journey of becoming certified orofacial myologists, therapy for speech down disorders that are associated with structure. And you are looking at a picture here of a tongue tie. So speech errors that we went over in assessment that are associated with structure. Bilabials may be affected by buccal or labial tots, upper lip insufficiency. This is when you get an overjet or an open bite or a cleft lip, where this tissue of the upper lip could be too short or too tight and not able to come down to meet the bottom lip. We often see challenges in feeding as well, with spoon feeding, or even as early as breast, bottle, puree, spoon feeding. It often goes hand in hand. Velar problems can be seen, speech sound errors of structure in lingual tots or cleft palate, the lingual alveolar sounds, tongue tie, tongue thrust disorders, dental malocclusion, high vaulted palate, oral resting posture issues, thumb sucking, prolonged pacifier use, biting of the nails, cleft palate. Lingual alveolar sounds are often impacted. And when therapists work in early intervention in the public schools, these lingual alveolars and the palatal sounds as well is often what we see referred to us. And often they're being dumped into that functional category of no known etiology or developmental phonological, when in fact that these lingual alveolar and palatal issues, whether they be incorrect placement. One of the things that I was talking about in the last course is, a lot of these articulation tests, we could be looking down and just listening and writing what the child's saying. And, we could hear love, like, lollipop, and we look at what the child's doing and they're saying love, like, lollipop, with the tongue thrusting and all the way outside the mouth, which isn't how that sound is standardly produced. Palatals, they're also affected by buccal, labial, and lingual tots, tongue thrusting, dental malocclusion, high vaulted palatal, the same things the lingual alveolar sounds are affected by, because when we do lingual alveolar placements or palatal placements, there's expected contact either between the tongue tip and the incisive papilla, or the posterior lateral margins of the tongue and the inner upper molars, with some contact between the tongue blade and the hard palate. And for example, if you have a really high vaulted palate, those placements are not going to be standard, and we're going to get a lot of distortions, a lot of lisping, a lot of lateralization. Dental sounds, like our F and V, labial tots and cleft palate can affect this, as well as lingual dentals, the voice and unvoiced TH, lingual tots, and especially when children have anterior dental issues, it's kind of a phenomenon. Their tongue is thrusting a lot and it's coming forward. Then you go to ask them to make the TH sounds and they say fuck. So Lori and I go into a lot of detail about this in our TOTS class, and I do as well in my systematic intervention for lingual elevation, or the SMILE program, when I teach a full day orofacial myofunctional approach to treatment for lisps. Let me just check over here because I have a red blinking light. Okay. So what's not functional? When you have an orofacial myofunctional disorder or a craniofacial disorder, and there are speech errors, this is not a functional problem. So we don't want to go to that functional speech sound disorders portal. We want to look to orofacial myofunctional therapy and oral placement therapy, which is based on Van Riper, who I mentioned before, his phonetic placement approach, because we are not dealing with some type of functional problem where we don't know the origin. So what does organic mean? It means that we know of an origin of where it's coming from. So let's start with orofacial myofunctional therapy. OMT is a treatment modality. It does not stand for a separate profession. Sometimes it's referred to as an orofacial myofunctional therapist. Orofacial myofunctional therapy is a treatment modality that falls under the scopes of practice of speech pathologists and registered dental hygienists, though dental hygienists do not practice the aspects of dysphagia or articulation that can occur or be comorbid with OMDs. The goals of OMT are first and foremost always establish a patent nasal airway. And this means that you can effectively correct a speech sound disorder with a child who has chronic congestion or an adult that has chronic congestion and breathes through their mouth. So the first step in doing oral facial myofunctional disorder assessment and then in a treatment plan is looking at the airway, the tonsils, the adenoids, and we did that in the assessment course. And in the therapy protocol, we need to get this patient to an ENT to rule out any kind of deviated septum, enlarged turbinates, large tonsils and adenoids, allergies, what's causing the patient to mouth breathe or have an open mouth posture. And we may also, to establish a patent nasal airway, be looking to dentists and orthodontists that can help expand that high vaulted palate. When the palate is high vaulted, it presses up on the floor of the sinus and it really narrows the airways. So by doing palatal expansion, we can establish a patent nasal airway. OMT also incorporates resistance exercises to help build muscle strength and endurance. It works on limiting non-nutritive sucking habits, modifying handling of a bolus, the oral stage of feeding. It helps to improve oral resting posture and improving articulatory placements, which is the focus of this course. But quite honestly, to get to that pink square you're seeing there, number 6, you really need to do 1, 2, 3, 4, 5 when you're dealing with OMDs. So let's go into a little further detail. When speech pathologists are trying to establish a patent nasal airway, this is a collaborative team between physicians, dentists, orthodontists, perhaps even respiratory therapists, and could involve physical and occupational therapies as well. We can practice oral versus nasal breathing, use tools such as horns and bubbles to differentiate oral and nasal airflow. We can use tools like a spirometer or a seascape, which you see here, to measure how much air is coming out of the mouth and how much air is coming out of the nose and differentiate nose versus mouth breathing. Encourage proper nasal hygiene before bed and throughout the day. I usually work with the ENT on that, designating perhaps a neti pot or a saline rinse with a good nose blow. Some patients need particular nose drops, like a Flonase or a Nasonex, working with the physician to figure out the best plan for that. Kinesiotaping, when trained properly, there's many speech pathologists that work with orofacial myofunctional therapy that do taping with children and adults, as you see in this bottom picture, to give kinesthetic and proprioceptive feedback to the muscles, to remind the lips and jaw where they're supposed to be in order to breathe through the nose. Using a mirror to look at nose clouds when the child or the adult is breathing, to give them a visual representation to practice breathing through the nose, and volitionally helping that patient practice nasal breathing while playing games, coloring, reading. In my SMILE program, the chapter on oral resting posture, these are actual techniques that I use with my patients. You're going to sit for 15 minutes and you're going to watch this video with your finger or your little mirror, and you're going to be aware of, while you're doing this, to breathe through your mouth. And if I breathe through your nose, and if I see you breathe through your mouth, I'm going to stop the video and we're going to talk about what we need to do and have some reminders and go back to it. So if there's something really motivating that the child wants, or we're going to color this picture, and I have a little bell here, and every time I hear or see you breathing through your mouth, I'm going to click the bell. I don't want to click the bell more than 5 times while you're coloring this project or building with Play-Doh. So, working bringing it from the use of tools, use every tool possible, and then shaping it more into the natural environment. Resistance exercises. There is a lot of controversy about this. And resistance exercises have to really be done the right way and with the proper background and training, because ASHA describes this, and I'll read it verbatim: exercises to improve tongue, lip, and jaw differentiation, including oral tactile stimulation and tongue movements without assistance from the jaw, such as tongue tip to the alveolar ridge or tongue clicks against the palate. Isotonic and isometric exercises target the lips and tongue in order to teach closed mouth resting posture and nasal breathing. So this is from their OMD practice portal, and that includes some of what we do, but certainly not all of it. But Heather Clark goes on to say, and this was in 2005 from the ASHA Wire, so this is 15 years before ASHA produced this portal, but I retrieved it on 1/18/20 as well. Evidence supporting the use of strength training for improving speech production is largely lacking, even for those conditions such as dysarthria where weakness is characteristic. The most promising evidence supporting strength training has come from dysphagia treatment research, but even in this literature, case studies and small controlled studies, given this, clinicians must assess critically whether there's an adequate rationale to use it. And the problem is, and I talked about this in the assessment, is that there's a fallacy in that we can't measure muscle strength or tone, and there's actually quite a few tools on the market for that. And in fact, in Europe, they're often used. But resistance exercises, you have to be really careful in what your goal is. For example, if we don't want a child to tongue thrust, we don't want to press against the tongue tip because the natural response is to push back. So we're actually reinforcing those muscle groups that are used for lingual protrusion. And this, by the way, is our new Sensi tool, and I have the nice tongue depressor tip on it. But using a resistance exercise on the side of the tongue to build up those intrinsic muscles that we need for lingual elongation that helps us with retraction, elevation, and back tongue side spread, that might be very useful if those muscles are very weak from dysarthria. So resistance training has to be very goal specific, and I really like the way it's described in the OMD practice portal, because what these patients often do is they compensate. So if the tongue is very weak and flaccid and low and forward in the mouth, they might fix in the jaw and they can't differentiate the tongue away from the jaw. So you have to strengthen that tongue to be so that it can work on its own. And while our muscles, only need adequate strength, many of our students and patients don't have adequate strength. So if we're going to use any type of resistance exercise in orofacial myofunctional therapy for structural disorders, we have to keep it goal focused. We want to keep it intraoral because working outside the mouth is not related to speech sound production, and we need adequate strength, okay? So sometimes there are some very valuable techniques that may be done. For example, when Lori and I teach our TOTS class, we talk about tongue on the shelf because we're trying to get the tongue to dissociate from the jaw. And since protrusion is the first step on the tongue-jaw dissociation hierarchy, we have protrusion, then retraction, then lateralization, then elevation, and then back tongue side spread. So if we can't even protrude our tongue without it resting or pointing downward or having tremor or fasciculations, we're not going to get anywhere with those movements we need for higher level sounds. So that might be important. Examples of resistance, I showed you this one, where you're pushing the tongue laterally against the tongue depressor. We have an exercise in our level 1 and 2 class that is a lip press where we hold a tongue depressor with weighted pennies on either side in between the lips. And that really is a great assistance in OMDs or structural disorders like cleft palate to get that sensory motor feedback of where the lips are supposed to be at rest and reduce that upper lip insufficiency that we deal with in cleft palate and lip tie. Using horns with increased resistance. So, for example, in talk tools, when we have horn number 1, this is a horn that requires very little breath support. I can like really just barely exhale, okay, and I'm going to get that lip closure, okay? But when I move to a horn, I'm just shaking the water out of them. I've been very busy in telepractice the past couple weeks, so I'm constantly washing my demonstration tools, using a horn as the resistance increases. So now I have a little bit of a similar mouthpiece. This one actually provokes more of lip rounding and protrusion than it does lip closure. But I need a lot more air to blow this horn. And I have to blow it for longer. So if I have to blow it for longer, I'm increasing that resistance of phonatory control, of lip pressure when I'm using the lips and rounding them on the tool. Or using lips to hold a button with an isometric pull. This is a very popular OMD exercise, and we've been doing it at Talk Tools for a long time. I'm going to use something a little silly because it's a little more visual, but this is one of our straw blocks, and this would go inside the lips. And then I would tie a string, and I could pull that string, which is being shown in this picture, so that there's a resistance there. There's an isometric pull. And I love this for OMDs when children have open bite and overbite and overjet or lip tie, and I'm working with them through their structural deficits so that they can also develop that lip strength for lip closure and a better oral resting posture. Orofacial myofunctional therapy also includes the elimination of non-nutritive sucking habits. And this is really important. Prolonged sucking of the thumb, pacifier, and tongue can result in high vaulted palate dental malocclusion that is going to result in speech sound challenges. So there's a lot of different information on this that I want to share. So when is it a problem? Because here we see a cute little girl. She looks about between 3 and 4, right? And she's got that pacifier. And, if you look at the OMD practice portal, it's quoting the American Academy of Pediatric Dentistry from 2014, which is still on their website, suggesting that children stop their sucking habits by the age of 3 or younger. They go on, the AAD goes on to say, if a child does not stop on his or her own, parents should discourage the habit after 4. However, excessive pressure to stop can do more harm than good. However, in orofacial myology, we often feel different than that. And this comes from our background in feeding, okay? So if we look at, for example, Diane Barr in her book, Nobody Taught Me or My Mother That, she talks about, they looked at pacifier use in almost 500 children in the year 2000. And there was a demonstrated connection between long-time pacifier use and middle ear infections. So Diane recommends guidelines for pacifier use on this study. And she talks about that there are other ways to calm babies between 5 and 6 months of age. Okay, so by that time, a child should also be exploring their own hands. They don't need a pacifier or thumb sucking to calm. Okay. And when they are using it, and parents have a tendency every time the child cries to kind of give them the pacifier, they're missing opportunities to make facial expressions, communicate, coo, and babble. And that's going to, over time, impede their feeding and subsequently their speech skills. And Lori and I agree in our book, A Sensory Motor Approach to Feeding, in Lori's course of the same title, and also when we teach our TOTS class and our myofunctional class, we talk about in the research, children start to have a psychological attachment with the pacifier at about 4 to 6 months of age. And at that time, this is when teething, non-discriminatory mouthing, and munch chew starts to develop. We're introducing the spoon. Soon thereafter, we're going to introduce solids. So this is the time to take the pacifier away or redirect that thumb sucking with a safe teething toy. So if you go past that 5 to 6 month age mark, what's going to happen is that psychological attachment's going to form. And then it is going to be really hard to break this habit once the child is a toddler, okay? And it's also important to differentiate that breastfeeding is not going to have this impact. Breastfeeding is one of the healthiest things that you can do for the mouth. So there's no issue with mothers wanting to breastfeed up until the toddler years in terms of mouth development. But that pacifier or thumb can have a really negative outcome. And Asha also says that non-nutritive sucking habits, including the pacifier after age 12 months, as well as finger, thumb, or tongue sucking, can have a detrimental effect on mouth development. So, what can you do in terms of therapy? So you may not, really be treating an articulation disorder in babies that are 4 to 6 months of age, but being a speech pathologist, I'm often surprised when I'm in like SLP mom groups on social media, how many speech pathologists defend the use of pacifiers and thumb sucking up until 3-4 years of age. And it's quite concerning that that's also available on dental websites, because when you talk to orthodontists or dentists that are really interested in airway orthodontists and myofunctional orthodontists, they will tell you that it's very detrimental as well. So at this 4 to 6 month old period, rather than encouraging the pacifier or thumb sucking, tools such as the Beckman Tri-Chew, and that's up in this upper right-hand corner, this green triangle. This is great, or the Chewy Q. Reason being is that they have a shape that the child can hold, and or a short nub that they're not going to gag or choke if using independently. This Infantino Good Bites carrot, readily available at like a Bye Bye Baby or a Target. This is really great because it has like an infant toothbrush at the end. Parent can use their finger inside. Baby can hold on both sides and really get some good teething done. These are the MAM teethers over here that are great. Water teethers, this is a cute little in the shape of a fish, can be put in the freezer, helps with teething, also encouraging that munch chew pattern that we want to see in babies start to develop it, between 6 and 7 months of age, so they can start moving on to baby-led weaning or small little cubes of food. This is one of my favorite things. This is a Kid Me food feeder. This you can put pieces of fruit or vegetable or a little baby mum cookie or a Gerber puff. And again, not dangerous. Baby can hold it and get it in the mouth and really practice that munch chew. And, these are exploring different textures, different flavors, different temperatures, and helping the baby along the path of good oral function and following the oral motor developmental norms. Once the child is 3 or 4, they can engage in a more formal program, and there are some great programs out there. And some of them include more positive reinforcement and can be very gentle, such as down here we have the David Decides About Thumb Sucking. We have this here at Talk Tools where it's a nice story to read with the child. Pacifiers are not forever. I use this in my office a lot. We have Pam Marshalla's guide on stopping thumb sucking, which has a lot of gentle techniques and positive reinforcement. But when things get really difficult and kids are maybe not fully responding to stickers and things of that nature, we can, in isolation, we can sometimes pair some helpers. There's the thumb buster seen here. It's a nice silky material that goes over the thumb at night. A lot of times kids also get the feedback in the skin and the callousing, and they're kind of trying to get that thumb wet, and it's a connection between the thumb and the palate. And it's important to understand that when noxious habits go on for this long, there's going to be a reason behind them. And it's usually not because mom kept giving them the pacifier. It's usually because there's an imbalance in the teeth or the oral facial structure, whether it's a tongue tie, high vaulted palate, quite often the airway. And that's where it becomes problematic too. I forgot to mention with babies, because a lot of the pediatricians want the pacifier in place up until an year of age because of SIDS, but the occurrence of SIDS after 6 months of age is very, very, very low. SIDS is really occurring between 0 and 6 months. So, once we're seeing this in 3 to 4-year-olds, we're probably seeing our tick errors, and these kids are ending up in our offices. And you have to ask yourself, well, why do they have this habit? And your tongue, if it's resting properly, has good contact with the hard palate, and that is a very soothing feeling. It provides a dopamine release. In fact, with all the stress from COVID and different challenges we're all facing, working, financial, our children, disappointment and canceled plans, one of my relaxation techniques is really focusing on my tongue in the resting spot to the hard palate and doing vagal breathing. It's very calming. So these children are missing this organization if they're mouth breathers, if their tongue is not sitting properly on the palate, and they're seeking that dopamine response, okay? And that's why we need a lot of things to help us stop it. So you have the thumb buster, Dr. Thumb, which you can see is more of a harder plastic that covers the thumb. Care Thumb, which is actually, different devices wrapping around the arm. So the child can't bend the arm to get the thumb in the mouth. It kind of blocks that. And then, there are some aversive tastes that can be used. When I got trained by Diana Davidson through the IAOM, they talked about this Mavala, stop nail biting. It could be placed on. There's some other noxious tastes. I usually use diluted clove oil or oregano oil. Very little in a coconut oil base that's placed on the thumb, and then perhaps taped. That way, if the child gets these devices off and they go to put the thumb in the mouth, there's a very noxious flavor. Every once in a while, I get a kid with sensory processing issues, maybe on the autism spectrum, and they like the taste. But what the clove oil does or oregano oil does is it also heals the skin. And a lot of times that's part of the problem. You bite your nails, you damage the cuticles, it makes the child bite them more. Or if they have a callus on the thumb, then they're sucking the callus. So the clove oil and or oregano oil with the coconut oil can help heal the skin as well. Here are some evidence-based practice, and you can look at this at your leisure later in the handout, but there are some pretty significant studies. Another one you may want to look at is Roberta Pierce in the IJAOM, and also Rosemary Van Norman, who did amazing studies on that correlation between pacifiers, thumb sucking, dental malocclusion, and possible implication on speech articulation. And this SHOT study from 2008 is a really good one as well. Another part of orofacial myofunctional therapy is oral resting posture. Your teeth or your molars should be very slightly apart. The lips should be closed. There should be a good lingual palatal seal, and you should be breathing through the nose. So OMT is going to target that. Ash is saying that the primary goal of OMT is to create, recapture, or stabilize a normal resting relationship between the tongue, lips, teeth, and jaw. Individuals who demonstrate these difficulties with the patency of their airway will remain mouth breathers. When the resting dimensions of that freeway space are altered, there could be, dental issues, and when you correct that in therapy, then dental stability should follow. And this is from Dr. Bob Mason, who has done a ton of work, and he also works a lot with Sandra Holtzman, who was mentioned in the last slide in regards to thumb sucking habits. And then not only Mason did work on this, but also Pasquet and Meyer and Satomi. When you achieve lips together, the lip competence is positively improved. And when your lip competence is improved, that influences as well where the tongue is in the mouth. So you want to have the lips closed and the tongue in the right position, because if the mouth's always open and the tongue is hanging forward, how is that going to affect speech? You're going to get a lot of those lingual alveolar sounds that are being made intradentally. The ASHA portal also talks about the oral resting posture can result in the tongue initiating speech sound production from an abnormal rest posture, which will also impact speech. And when it's related to abnormal labial lingual mouth open pattern or breathing, it will result in articulation errors, and you can expect the articulation errors to be more readily remediated once that pattern behavior is corrected in therapy. So that goes back to that first slide. If you want to get to the pink square and work on the articulation, you have to work on all these things I've mentioned prior. But again, very confusing. Then when they talk about, well, how do you remediate the speech? They bounce you back to that speech sound disorder, articulation, phonology, and they really don't talk about how you approach those speech sounds. Book references that you can get a lot on the relationship of oral resting posture, dentition, oral habits, and speech is the famous book by Hansen and Mason, Oral-Facial Myology, and then William Prophet, Contemporary Orthodontics. And if you're thinking about getting your COM through the IAOM, get your hands on these books now because you're going to need them for your training. An OMT program also considers, as I talked about, manipulating a bolus. It involves the oral phase of feeding. Oh, we got a little blurry stuff on the bottom here. Sorry about that. A feeding program according to Overland and Merkel Walsh in a sensory motor approach to feeding. Yes, that's me. I'm Merkel Walsh. We talk about the position of the body when doing oral phase feeding, what kind of foods we're going to choose, just like we looked at the teethers and the mouthing toys, and we wanted taste and we wanted texture and we wanted temperature. We want to consider that in the foods we're going to use. That the placement of the food influences the motor skill. So if there's a tongue tie, for example, and you're placing a bolus in the middle of the mouth, moving it to the molar to chew it, which is appropriate, is going to be difficult. So if we want to improve mastication and strength in the buccinator muscles, in the masseter muscles, in the orbicularis oris for closing the lips, and how that's going to translate into bilabials and tongue tip elevation, swallowing, and speech, we want to watch where we put the food to influence the motor skill. We consider supports. Are we going to need to give jaw support? Are we going to need special utensils? We use really big forks here in the United States, sometimes using a coffee stir, a cocktail fork, using the appropriate spoon, the appropriate straw, not having a sippy cup. All of that is going to be very important. So some examples, position, posture, and alignment. We want the body in 90-degree angles. Maybe we'll consider adaptive equipment from PT and OT. Our food choices, we want to give high input. We want textures that are easy to manipulate in the beginning when we're teaching in a proper chew, a proper swallow. We want things that are sour, that are spicy, that are salty, so the patient or the student can feel the food in the mouth. We'll use utensils such as straws with blocks, coffee cups with a raised lid, so you could get really good lip closure. Those are things that can influence lip closure and tongue retraction, which we want as a prerequisite skill in oral-facial myofunctional therapy for both swallowing and speech. Placing the food on the molars to encourage an appropriate rotary chew, making sure that we're practicing how the bolus is formed and brought to the top of the tongue, organizing that bolus, and then different supports like practicing tongue to the spot, maybe using myo bands, swallowing saliva, and then maybe even getting into some commercial programs like my Smile program. Chart has Swallow Works, which is wonderful. Pat Pine, for example, has a TOTS program, Please Release Me. So looking for those supports that are going to work us into those prerequisite feeding and muscle-based skills to correct a structural issue that is impacting articulation. We look at the oral phase of the swallow. Jaw position should be high, lips should be closed, tongue tip should be elevated. We need lingual palatal suctioning and back tongue elevation. If you want to learn more about this, I suggest my tongue thrust class, my oral facial myofunctional class. It's a lot to go over in detail in a 2-hour webinar, but I want to bring it to your attention because when you're using oral facial myofunctional therapy, to work on speech sounds, we do, also work on improvement of that oral phase of swallowing. And while there's not a one-to-one connection between speech and swallowing, we know they're fired by different nerves. We use the same muscles, okay? And some of this OMT is also going to be also valuable when we talk a little later on about muscle-based disorders such as dysarthria, because they often go hand in hand. Here's some of those programs that I was mentioning before: Swallow Right, Smile, and Swallow Works. There are 3 step-by-step programs that use orofacial myofunctional therapy to help with swallowing and speech. My program's a little bit different in that it incorporates speech, swallowing, oral resting, and noxious habits all in the same program. So where you may be working on one of the other programs and you supplement with like unplugging the thumb, or David decides about thumb sucking, or you're going to run an oral resting nasal patency program. It's all included in Smile, including the tools. I wanted to make it really user friendly. So for this section, if you're looking for some feeding references, on the Oral Motor Institute, Diane Barr and Christy Gatto, certified oral-facial myologists, were kind enough to share with us their reference and research from the ASHA convention 2 years ago. And Talk Tools also has a master reference list from peer-reviewed journals on our website. So finally, speech sounds. What are we going to be working on in structural? So we use that orofacial myofunctional therapy to target the underlying issues of the structure. And then we can use our oral placement therapy with patients under the age of under 4 years of age, OMT. Sometimes we really need these patients to be 3, 4 and up because they need volitional control to monitor all these things. I can't suck my thumb, my lips need to be closed, I need to breathe through my mouth. With oral placement therapy, we can work on dissociation and grading of the jaw, lips, and tongue for respiration, phonation, placement, manner voicing, co-articulation, precision, all that lead to improved speech clarity. And all are mentioned, if you remember, in that review from assessment. All of these things are associated with structural deficits. So what we want to think about is we want to say yes to correct placement, and we want to say no to compensatory placements, because we're learning in this little snippet about structure. We don't want the tongue resting in a way or pushing in a way that's going to result in dental malocclusion, that results in a high palate, that results in, difficulty with breathing through the nose. We want to teach sounds the right way, okay? The way they're supposed to be produced. So what are some, examples of OPT if you're not familiar with it? The jaw is the foundation for speech movements. In graduate school, they taught us a lot about what the lips and the tongue need to be doing and manner and voicing, but they didn't teach us that each speech sound, each vowel, has a specific jaw height, okay? And if a patient has an OMD and a structural issue, or they have cleft palate and narrow airways and difficulty breathing in an open mouth, they may always be like this and not really have good jaw strength and stability in a higher plane of movement. So we may be using a bite block to work on that resistance that was mentioned before, in giving an isometric pull and working on that jaw being stable. I use this a lot. For example, a child is trying to make the S sound and they can't do co-articulation. I use this bite block here to give them a cue of not only what jaw height they need to be in, but centralized airflow. You want to work on, for example, lip protrusion, for that SH, that R, that CH, that often is a problem with cleft palate, with TOT structural deficits. I can use this horn 3 that I showed you before, and I'm getting that tension in that upper lip to start practicing the shushing sound, getting that posture, or working on, like Sarah Johnson talked about, the duckbill and the dinosaur, in doing the E and the pressing those lips forward. If they can't get that placement, I can get at that horn and I can work on that. If I have a cleft palate patient and they're having difficulty with lip rounding for W and O vowels, I can get out my bubbles. Just give me 1 second. Missing a little tube here. Here it is. So I'm getting, instead of when, then. Or I can't get ooh, I'm getting an with the distortion. I can use a pop tube in our bubble kit, and I can place that in the lips before blowing the bubbles to shape, and then I can shape that right into a speech sound. If I can't get tongue retraction with elevation for an L, I can take a medium height bite lock, and I can use the Sensi tool under the tongue and lift that tongue for the student or patient into place. So they can feel. They may not be able to imitate right away, but then when I teach them how to feel the placement with the tools, that could be very helpful. Now, there's a lot of controversy. We know that Dr. Loff has talked about you don't need to blow a horn and it has nothing to do with speech sounds, okay? And even in the American Cleft Palate and Craniofacial Association Journal, pretty recently in 2018, they talked about blowing should not be used, use biofeedback, nasal pharyngoscopy, nasometry, articulation drills. You don't have to use blowing. But in the new guide that was published in 2019 by Pam Marshala, she brings attention to there's been little proof for effectiveness across all of these methods in the literature, including the biofeedback, the nasopharyngoscopy. There seems to be better research in biofeedback with the nasometer and the C-scape. Manipulating speech sounds, like being phoneme specific or exaggerating speech. But scripture started talking about blowing in 1912. And Belt also talked about blowing in 1906 as an indirect method of velar control. And then Van Riper in the 50s and 60s also said we need to do blowing and then right away practice speech. So it really boils down to we're not trying to say that blowing directly helps the speech by itself and you do blow, blow, blow and you run out into the sunset and your kid is discharged and that's all you have to do. The blowing, it's very difficult to teach children resonance, as we know, is an issue with structural deficits and what oral and phonatory control and all these different things are. So it comes down to using these tools in oral placement therapy for awareness and then helping shape that into the speech sounds. So this isn't a new concept, okay? Yes, if you want to try to do a study and just blow a horn and prove that it's going to make the S sound okay, no, we're not going to find that. But we're definitely going to find a lot of evidence of the effectiveness of using these tools for oral motor sensory awareness. Marshala also talks about in her book multi-sensory multimodal cueing using assigned alphabet, imaginary cues like visualize this in your mind, homemade phonetic cues, hand models, tactile cues. You know, we have systems like prompt therapy that are very tactile, but sometimes we just make them up in therapy and they work and we see clinically, hey, I've learned that if a child is doing a V instead of a B, and I do what I call thumbprint technique, I take my thumb, I go right into the mentalis, and I push upward a little to kind of release that lower lip retraction. It's a great tactile cue, and I can get a bilabial sound that I need. Prompt therapy, Marshalla has place cues, Linda Mood, phonetic sequencing. So it's that oral placement therapy, combined. As I said in the beginning, it's not always a one size fits all approach. We can use multimodality when we're dealing with structural deficits that are impacting speech sound disorders. We're having a tougher battle because it's not functional where it's going to respond very quickly to listen to the sound, say the sound, practice the sound, and discharge. We're working with that uphill obstacle that when you're dealing with structural deficits, you're often dealing with muscular-based deficits as well. So you can look at this later. There's a lot of great studies here, like by Green and Moore and Messner, and posters that we've done at ASHA and the IAOM and Merdad, and Moore and Rourke studies, Siegel, Morris, Schatz. All of these are great studies to look at impact of pacifiers, studies about feeding and pre-speech skills and how they impact articulation, how TOTS will have functional impact on feeding and speech. So you can take a look at all of these at your leisure. You can even cut and paste them into your search bar to pull up the whole articles. And I always recommend read the whole article, because a lot of times, especially in some recent publications that have come out on tongue tie, they're taking small pieces of the study to use it for their hypothesis, and they're not looking at the whole picture of the study and looking at all the data that was achieved. So read the studies for yourself. Okay, we're going to move into motor planning. And what I'm going to do is I'm just going to take a quick 5-minute break for everyone in case you need the restroom, you need to get a drink, any technical issues that you need to sort out with Lisa. It is about 2 minutes after 5. Let's come back at 5:07 and start with motor planning. Okay, I'm back. So now we're going to move on to.
Hey, Robin,
Yes.
I can't see your presentation.
Okay, I didn't. Can you see it now?
No, can you go to share screen?
Yeah.
Or there, okay,
Got it.
got it.
Okay. So now we're going to talk about speech disorders that are associated with motor planning, and we'll start with childhood apraxia of speech. Apraxia Kids defines childhood apraxia of speech as a motor speech disorder that first becomes apparent as a young child is learning speech. For reasons not fully yet understood, children with apraxia of speech have great difficulty planning and producing precisely, highly refined and specific series of movements of the tongue, lips, jaw, and palate that are necessary for intelligible speech. Sorry about that. Trying to get the. Now, ASHA adds to their website that for CAS, there, in terms of therapy, there are motor programming approaches for using motor learning principles and including the need for many repetitions, that there are linguistic approaches that focus on CAS as a part of a language learning disorder. So they're really building the therapy around language units, combining motor and linguistic, and then more rhythmic or prosodic approaches such as melodic intonation therapy. So let's look at some of these. For example, dynamic temporal and tactile cueing. This is an integral stimulation, look, listen, do what I do. And it's very highly used by and developed by Dr. Edie Strand. It uses a cueing hierarchy, auditory, visual, and tactile, and it's very systematic. So these are one of these approaches that you need to go and get trained in specifically in DTTC. And I know at the Apraxia Kids site, this is listed as one of their evidence-based approaches to childhood apraxia of speech. Then you have the Nuffield Dyspraxia Program, the NDP3. That's a motor skills learning program. It emphasizes motor skills and speech output. It's described as a bottom-up approach. So they work on core units of speech and single speech sounds, and then they go to syllables and then to CVC. So it's not too dissimilar from, let's say, Nancy Kaufman's program, where she's also, starting with a small segment and then building the word. Okay. And this is from the ASHA CAS portal. They also include as an evidence-based approach rapid syllable transitions, which is called REST. It involves repetitions and varied sequences of nonsense syllables to train motor planning flexibility. Velleman and Strand were also involved in this. Think of diadochokinesis. It's very paralleled. It has a lot of intensive practice producing multi-syllabic, different types of pseudo words to improve accuracy of speech before they start actually working on speech words. And then there's also the linguistic approaches, and I was quite surprised to find that Hodson's cycle approach, which we usually think of for more functionally based speech sound disorders or developmental phonological processes, are being used with CAS patients who need a lot of functional communication. So they target speech in a more traditional manner where they're using groups of sounds, like we're going to work on velars, we're going to work on bilabials, and approach those in cycles, because they have found that it works with children with functional speech sound disorders or phonological processes that are highly unintelligible. So they started looking at that with children with CAS. And then that prosodic facilitation, this uses melody, rhythm, stress. It can use music, singing, rhymes and riddles, tapping, a lot of things that, and we mentioned before about CAS and disfluencies. Think about some of the prosodic facilitation techniques that are used for disfluencies. They're using those as well for kids with CAS. But here's something very interesting. I highly respect apraxiakids.org. There's a lot of great professionals on that. David Hammer and Dr. Strand and Dr. Vellman, among many other therapists. But even on apraxiakids.org, this is what it says. They asked, do we have a lot of level 1 studies? And they're honest and they say, no, we have a few meta-analysis studies and systematic reviews available. For example, Murray, McCabe, and Ballard wrote a systematic review in 2014, which was worth examining. But most of the CAS studies are done with relatively small samples. So they say, that being said, the research is still given some answers about the best approaches for working. By looking at the evidence, a speech language pathologist can determine which approaches will likely work and most likely will not work. But let's look at some of the studies that are there for CAS. They're using subjects with pure CAS. And I don't know about you, but I'm rarely finding these kids in my practice because I don't have kids with CAS that can readily sit and work on melodic intonation and repeating nonsense words and a bunch of syllables and doing it over and over again, okay? So if we look at an article in 2006, which is often cited by Strand, Stockel, and Boss, the treatment of severe apraxia of speech from 2006, it had reported treatment in 4 young males with severe CAS. The subjects range from 5'5" to 6'1". They were essentially nonverbal. They received 2 years of previous treatment, and each child received 2 30-minute treatment sessions a day, 5 days a week, and received about 38 to 50 sessions total. And the majority of the children in the study, 3 out of 4, made gains. The one that did not had, variability in frequency or practice of the session. So this was really a study to look at the fact that kids with apraxia of speech need intensive therapy a lot of times a week. And a lot of times parents of children with CAS will use that to get those kind of services from the school. But Renee Roy Hill, my colleague from Talk Tools, just did a TISHA presentation in 2019. And she looked at some of these evidence-based approaches that are in the literature, DTTC. What if there aren't enough speech sounds or syllables to imitate? So if you're going to do that repetition and use this tactile cueing, what if there's a limited phonemic repertoire? Rest, what if the child can't sustain sitting for the scripted amount of time? Or what if they don't have consistent vowels and consonants required to do the practice that's required? The NDP3, what if the child doesn't respond to visual and auditory cues and they need tactile cues? So why are organizations or therapists shunning therapies such as Prompt, the Prompt Institute, or the Apraxia Kit by our colleague Renee Roy Hill? Because they're telling us that they don't have a lot of level 1 studies either. They have small case studies. And I will give you the evidence. Certainly, there is evidence for prompt and tactile methods such as Renee's program for those children with apraxia that don't have, number 1, pure apraxia, where it's just motor planning. They may have some motor execution and structural mild functional issues as well. And they may not have the attention, the sustainability, especially our kids with autism, who we know that 67% of kids that are diagnosed with autism have comorbid apraxia of speech. So that's important to consider. There's very positive clinical data for other programs out there, such as Nancy Kaufman's KSLP1 and 2, Carrie Ebert's Silly Sounds, Renee's Apraxia Kit, and also phonetic placement therapy. We find at Talk Tools a lot of positive outcomes in using tactile approaches with our horn, straw, bubble, bite block kits, and even some of our myofunctional protocols for phonetic placement with children with CAS. So if you want some prompt evidence, I have it both for childhood apraxia of speech and with Broca's aphasia and adult apraxia as well. There is clinical evidence base for Nancy's work and for Renee's work, so you could take a look at these studies. We don't test every tool in speech pathology that we use. Like, no one's done a study on a mirror to see if it gives better articulation placements, but we know that it does, okay? So a lot of the tools that we use that are on the market are based more on the philosophy behind the tool. So for example, Renee created her apraxia kit based on the apraxia research of Caruso, and you know, there's studies out there. I said that incorrectly. I'm sorry. With Renee's kit, it was criticized at Nagisha by Caruso and Elisef, saying there wasn't any studies for the efficacy of the tool, but the program is based on Van Riper's research, the feedback mile by Mizak, and common sequencing by Young and Hawk that are dating back as early as 1954. So these concepts have been around in our fields for a very long time. There's also the motokinesthetic approach, which is a basis for a lot of the apraxia kit. It was the first speech movement training. It was developed by Young and Hawk. It talks about manual manipulation of the peripheral speech system and the direction of airflow. It emphasizes correct movement patterns. And if you want to learn more about that, Pam has pretty much a whole chapter in her new book about motokinesthetic approaches. There's a really good article in the Journal of Developmental Pediatrics from 2015, how valid is the checklist for autism spectrum disorder when a child has childhood apraxia of speech. I recommend that you take a look at that as well. The results showed that 63.6% of children initially diagnosed with autism also had apraxia, and that 36.8% of kids that were initially diagnosed with apraxia also had autism. So there's a correlation there. And remember that many kids with CAS also have comorbid muscle-based issues. They have oral facial myofunctional issues. They can't respond to look at me, say what I say. They benefit from tactile cues and from analyzing a motor skill and breaking it down into segments. They may need assistance and supports with jaw-lip-tongue dissociation, and they require working from their best motor planning unit and then moving to a more difficult one. And this is the foundations of the Kaufman praxis, of the oral placement to speech card program, and also moving across syllables, which is another great speech sound program. So if you want to look later on, this is some of the evidence I collected for CAS. Now, we won't spend as much time on this, but acquired apraxia of speech is a neurological speech disorder. It impairs the capacity to plan or program sensory motor commands for directing speech movements. It may be referred to in the literature as verbal apraxia or dyspraxia. Neurologists often delineate this as apraxia is an absence of and dyspraxia is less severe. It's a disorder of. AOS also can co-occur with dysarthria. and sometimes with limb apraxia, oral apraxia, and gait, swallowing disorders. It does, by true definition, it doesn't involve muscle weakness or paralysis or spasticity or involuntary muscles. We usually know and can tell by the lesion in the brain if there is acquired apraxia of speech affecting Broca's area. How do we treat it? What is evidence-based? There's kinematic approaches that are based on motor programming and planning. It provides very frequent and intense practice of speech, not too dissimilar from what's being talked about with children. In adults, they often use augmentative and alternative AAC approaches, which can be used with children as well. It gives them those communic options and supports because their brain might be functioning completely normally from a language point of view, but they can't get the message down. So they need something to ease the frustration. And those are the two pretty much basic approaches that have the most evidence base. But I did find a lot of different studies in neurological diseases, brain injury, if you want to take a look at that. And Dr. Strand and Duffy, they also work with kids, but they also study acquired apraxia of speech as well. As you can see, there's a ton of research, differential diagnosis, and using motor guided learning. So you can take a look at that. It's not really debated in the literature, and it's not as complicated as working with children because we know where the site of lesion is and we know what's causing it. And it's a rehab form of speech therapy. So the person had it and lost it, and we're working on them getting it back. It's not that they never had it at all. So finally, let's look at therapy for speech sound disorders that's associated with muscle, muscle strength. Often Dr. Loft's paper at the ASHA convention, it was a presentation and a paper in 2009, is misquoted as ASHA's position statement on muscle-based disorders and non-speech oral motor exercise, and it is not. What Dr. Loft said is articulatory strength needs to be very low for speech, and speaking strength does not come close to the maximum strength abilities of the articulators. For example, lip muscle force for speaking is only about 10 to 20% of the maximal capabilities for lip force, and we only use 11 to 15%. He also says that only a fraction of maximum range force is used in speech production. So strengthening tasks for the tongue, for example, are not necessary. This is not a position statement, just like ASHA doesn't have a stance on what I talked about on tongue tie at last year's convention. It is simply a presentation. Dr. Loft also said, however, that phonetic placement cues that are used in traditional therapy are not the same as non-speech oral motor exercises. And what I mentioned before is that oral placement therapy is very much based on Van Riper's phonetic placement. So we need to think about that as we talk about muscle dysfunction. This is additional research on the muscles that don't necessarily agree with Dr. Loft's paper, so you can take a look at these. In the ASHA portal, it's very interesting. There is an adult dysarthria portal, but there's no clarification at this point in time for children who are demonstrating muscle-based or muscle execution, motor execution problems that are very similar to dysarthria. So we have to look at the research in adults, okay? So dysarthria can affect a lot of systems, okay? So they're saying their evidence is respiration, the individual blows into a pressure threshold device, phonation, Lee Silverman voice treatment, phonetic placement techniques for ARTIC, which that would include OPT, resonance, looking at prosthetic management or resistance training during speech, and prosody as being important treatment goals in dysarthria. And that really reminds me of something, because at Talk Tools, when we work with children that present with the same signs and symptoms of dysarthria or muscle-based dysfunction in adults, we too target respiration, increasing resistance through our horn hierarchy. We too work on articulation with phonetic placement. For example, something like our tongue tip elevation tool, where we have a tool with our little ball that we can use to hold the tongue tip up to the spot and give that phonetic placement. And we also work with resonance with prosthetics and resistance, such as using nose clips, or we use a really fun tool called a nose flute, where also very good for that OMT that we talked about before. I have very bad allergies right now, so where we're differentiating oral from nasal, and that's fun for kids. And muscle-based programs can be found by Diane Barr, Deborah Beckman, Pam Marshala, Morrison Klein, Sharp Oshar, Sarah Rosenfeld Johnson. I give her the biggest square because she was my main teacher, and our founder here at Talk Tools. But what these clinicians have done is really taken the principles of dysarthria therapy in adults, because we recognize the signs and symptoms in children. And this was a poster session I did. We have it on the website. It's a little blurry. You can look it up later. A modern look at Van Riper's phonetic placement approach. And I talk about and Pam Marshala talks about this too, in the early times of speech pathology, the early 1900s, we were using things all the way up into the 70s, 80s, and early 90s that might have not been safe for the mouth. Feathers, matchbooks, craft sticks, pipe cleaners, rubber bands. And they were considered phonetic placement therapy. It was never a problem. And innovators started coming in, like Sarah, like Lori, like Sharboshart, like Deborah Beckman, and developing tools that were safer and more appropriate for phonetic placement therapy. And it was very interesting when I did this at ASHA Connect, because if I put up oral placement therapy, I might not have as many professors and researchers, but I had a huge crew at this, and I broke through a lot of barriers with this poster session and my research. And what it taught is that oral placement is based on muscle and motor patterns needing to achieve a speech sound, that we only use speech-like movements, that we include respiration, phonation, resonation, voicing, and positioning of the articulators, that we do not work on blowing to just for no reason. We use it for proper inhalation and exhalation, and the tools may be used to do that. Our tools are not chosen randomly, but based on that task analysis of each speech sound. And once we can achieve this speech sound, just like Van Riper said, we go right into direct therapy. So as you probably figured out already, there's a real overlap of oral placement therapy and orofacial myofunctional therapy in using a muscle-based approach when we're talking about muscle-based dysfunction in both children and adults. So I wanted to give you, before we do Q&A, some structure word ideas. So I developed oral placement to speech with Sarah Rosenfeld Johnson, and I'm also prompt trained, and I'm also Beckman protocol certified, and I'm also a COM. So I come from a lot of different areas of study of structure, motor, and muscle. And I found some really handy tips, and I've done some webinars. You may have taken them in the past, choosing words wisely and oral placement to speech. And I've combined some of those ideas to kind of categorize what what type of words should be working with, okay? So from choosing words wisely, when we're working with structure, we should consider that we want to target lip closure to support that oral resting posture. Because remember, with structure, we have a hierarchy. What do we need to do? We need to get nasal breathing, we need to get lip closure and tongue retraction. So words that encourage lip closure and the jaw in a high position will really help support those goals, like me, beep, poop, peep, pee, beam, bee, moon, boo, poo, mo, and bo. And these are available in oral placement to speech, and some of them are also available in the Kaufman Praxis Kit 1 in her bilabial assimilation, her bilabial synthesis, and some of the CV cards as well. What we also want to consider is that velars can help with tongue retraction, and when we pair that with oral resting posture practice and swallowing, this can be really positive, because whether we're dealing with cleft palate or tongue tie or open mouth posture, one of the deficits in speech these kids often have is they're not getting good VP closure, and they have very nasally sound. Because if I hold my tongue all the way down in the floor of my mouth, this is what I'm going to sound like. So it's just assumed, well, you know, they have velopharyngeal insufficiency or velopharyngeal dysfunction, and we're going to take a VPD approach to treatment, but you can really work on bombardment of velars and even pair it with bilabials. So you're targeting that oral rest posture, that tongue retraction, and VP closure. So these words are also from oral placement to speech, including gag, gack, cat, cob, cab, cap, cod, cork, gawk, keg. So you're really articulating and drilling those velar sounds. You also want to consider alveolars with structure for tongue tip elevation and swallowing before going into treat a lisp, because if you're getting Thup Sunday or Sunny Sundays, you have to check that placement. Our T, D, L, and N, the more earlier developing lingual alveolars, is there good placement with them? And you can work in the high to mid jaw range, because T, D, N, and L are made in that high to mid jaw range for sound production. So you don't need a lot of jaw grading. You take the jaw out of the equation, you stabilize the jaw, done, net, ton, nod, nut, you get the picture. You can really focus on that tongue tip placement, and you can use your tools like I showed you before. If you want to use the Sensi or you want to use the tongue elevation tool and the little ball to get the tongue tip up, these are really good words to do when you're dealing with structural deficits. And finally, consider palatals and the relationship of the lingual palatal suctioning. And these words I achieve from moving across syllables. So you want to stay in, again, in that high to mid jaw plane, but these structural problems, if they don't have a good oral resting posture, they're not getting good contact between the mid blade of the tongue and the lateral margins of the tongue with the palate and the upper molars. So again, if you stay in one plane of movement, chew, show, shin, shoot, chic, sheet, read, ear, you're going to get a much better chance at articulatory precision of those palatal sounds than you would if you're pairing them with these, low jaw vowels or high jaw vowels that are creating a lot of grading. You want to stay in that high mid range. Praxis word ideas. Units per word. If we look at all these evidence-based CAS and AOS treatments, consider the best place of movement for the particular patient. Do they do better with really wide jaw excursions like ma, 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 or me, me, me? I learned in prompt training, you want to start with their best plane of movement. Consider jaw grading. How many jaw heights are you making them go through? In the oral placement to speech program, we divide our words by easy, moderate, and difficult, in that easy words are going to have no jaw grading at all. You're going to stay in all one plane of movement, and difficult words, you're going to get a lot of jaw grading. So you want to start with less jaw grading and move your way up. So you're considering jaw shift units in different words. Consider voicing. Is it easier for them to do voiceless versus voice sounds? So if voiceless sounds are easier, work on all your voiceless sounds. And that kind of goes more with a traditional approach that we might do with functional patients. Consider the amount of place shifts bilabial, a word like Bob versus a word like back, where you're changing the articulatory placement, or a word like none, where there's synthesis on the end of the front and the back of the word, where if you're saying a word like lush, that might cause more errors to the L sound, because now the SH, it's too many place shifts. Consider closure on the unit. So for a lot of kids with apraxia or adults, it might be easier to say CV units before they can say CVC units. Consider the labial shifts. Are you doing words that you're expecting the lips to retract, round, and protrude? So if you said a word like sheep, you would be doing protrusion, retraction, and then closure, all in the same word, and that might be too difficult. So maybe keep the W, which is rounding, with a rounded vowel to build up those units per word. And also the lingual shifts, remembering that the tongue in speech, it could protrude like the TH, it retracts on vowels and all the other sounds. It can elevate with our lingual alveolars. We can get back tongue side spread with our palatal sounds. So a program like moving across syllables is great for a lot of these words, because they organize the words by place shifts, the labial shifts, the lingual shifts, and you can pick the easier words to start with. Excellent products for childhood apraxia of speech. The Kaufman Praxis, both the cards and the workbook, carry Ebert's Silly Sounds, Easy Does It, the Apraxia Protocol, the Flip Book from Super Duper, Moving Across Syllables, and Prompt Smart Cards. And finally, for muscle-based word idea, I mentioned oral placement to speech. This program identifies jaw stability and grading between consonants and vowels and targets all early developing sounds. We already analyzed the place shifts and organize words into easy, moderate, and difficult, so that you don't need to do that. And it also comes with the muscle-based oral placement techniques that you would need to do in case the client or the student cannot effectively say the words. And it avoids any conflicting sounds. So think about, you order a card set for P and you get words like caterpillar, or you're ordering a card set for B and the word is school bus, and there's just too many hard sounds within the card set. So if you're working with those littles, especially if they have muscle and motor base together, this is a very helpful program. So just a quick visual. In the easy words, there'll be no place shifts or competing sounds. They're all in the same plane of movement. When you do a moderate word, there's only one place shift. There's no competing sounds. And we considered voicing and manner to make the words a little more challenging. And then when we got to the difficult words, we did 2 place jaw shifts. We didn't put in competing words, but we challenged the client with more challenging voicing changes. Like here, we're going from voiced B to unvoiced K. and more challenges in co-articulation. So in summary, diagnosis drives therapy. We need to conduct a proper assessment, look for speech patterns associated with the structure, motor, execution, or muscle, recognize that these diagnoses overlap. We choose therapy methods based on all five levels of evidence, including clinical feedback and patient values. We become flexible so that we can combine approaches, and we choose our words wisely. I am going to open up the floor to some questions. If we do run out of time, a couple of important things. If you have any issues with anything in terms of getting your CEs or not receiving an email with your survey, please contact continuing education at talktools.com. I cannot help you with that. If you have product questions or you're interested in other webinars or live trainings, there's a little typo there, so I'll fix it right now. Sorry about that. It is customercare@talktools.com. And if you need any clinical questions, my email is on my private practice website. But please just don't email me with the CE questions. And if we don't get to all the questions today, Lisa will be very kind and forward me anything that's not answered. So Lisa, I'm just going to ask, do we have any questions?
Yes, we just got our first question from Elizabeth. She says, "Hi, Robin. What is the difference between the older oral replacement to speech kit and the newer version?"
What we've done is we have updated we got a lot of feedback from our customers that they found the directions rather confusing. So I took a lot of time in simplifying the directions and making them more user friendly. The actual card sets are exactly the same. It is a tweaking to the actual program use to make it more friendly to the clinician.
Perfect. So I guess we can wait she said thank you. We'll wait a few more minutes for some more questions. But thank you, Robin, for this wonderful webinar today. And always, you're always bringing great webinars to Talk Tools. And I just wanted to remind everyone that Robin does have a webinar in our online conference that is scheduled next month between May 8th and 16th. So we hope you check that out. You will be receiving a discount code in your email, your post email, that you'll get within the next 3 business days. So you can definitely use that towards the online conference.
Yeah, it's going to be great. This is really exciting, and especially with all the stress that we have in our lives and trying to get CEUs, and it's very multidisciplinary and covering a lot of important topics. And hopefully we'll be back to some form of normalcy. I know it's different for everyone. I'm in New Jersey, so we're really on like a full lockdown here. We still don't have a lot of necessary types of supplies like cleaning products and paper products and dairy products and things of this nature. I know in other places they're starting to open up a little bit. So hopefully we'll be in a better place by then. But whether we are or not, the virtual learning makes it really easy for all of us. I'm looking forward to listening to some of these webinars myself. Okay,
all right, Robin. Yeah.
Be safe, be well, and see you soon.
Thank you.
Welcome.